Medical information on this site is provided as an information resource only and is not to be used or relied on for any diagnostic or treatment purposes. This information does not create any patient-physician relationship and should not be used as a substitute for professional diagnosis and treatment. Please consult your healthcare provider before making any healthcare decisions or for guidance about a specific medical condition. Doctors Ruhoy and Kaufman shall have no liability for any damages, loss, injury, or liability whatsoever suffered as a result of your reliance on the information contained in this site.
Hi, welcome back to Unraveled, Understanding Complex Illness. Is it Understanding Chronic and Complex or just complex? Just complex only. I'm Eileen Ruhoy.
I'm David Kaufman.
That's David. I'm your friendly neurologist, neighborhood neurologist.
I don't know what I am anymore.
You're the best doctor I know.
No,
that's who you are. And the best human. We're going to actually talk again today about ICT because I've been getting a lot of questions about ICT. How about
What's
you?
What's ICT? What's it stand for? Just in case.
Invasive cervical traction.
So that's the first problem.
That is the first problem.
Just so you know, it shouldn't be called invasive. That scares the shit out of everybody.
It does scare a lot of people.
Excuse me, scares everybody. All right, it sounds
maybe
like
intense cervical traction. We can talk to
intense. Yeah, then you won't have to change the initial. That's a good idea.
Yeah, I like that. I'm going to talk to Paulo about that.
Idiopathic cervical traction.
We call it iatrogenic
cervical traction.
Iatrogenic cervical traction. That's a good one. That's going to imply we're going to hurt people.
Yeah, let's go back on track. Sorry.
So we're going to, yeah.
What are we talking about?
ICT. Because we get a lot of questions, I mean, even from doctors and from patients. And for some reason, I guess because we're so close to this world, that I actually thought that everyone knew what ICT was at this point.
Well, I mean, in fairness to everybody, I never heard of it until 10 years ago when I met Bolognese. So actually when I had Jeff as a patient and then met Bolognese. So yeah, I'm not surprised people don't know what it is.
Yeah, I guess you're right. But years later,
I know
people still
But you're right. Then you and I think of it like I wake up thinking about it, but that's not the way most people are.
That's right. Most people have better lives than we do. But also in fairness, the ICT has evolved over the years.
Right.
So there's always some slight difference to what people always perceive it may be. So we thought that it would be worthy of a conversation again.
Yes.
Since I have recently been getting lots of questions and, excitedly so from other doctors and other institutions that are sort of interested in considering, how best to treat and evaluate for things like CCI in EDS patients. So that's nice.
As we discuss it, I don't want to forget to be sure that we add in how do you prepare for it and how do you plan for post-ICT.
Oh.
Okay? Because that comes up all the time.
Right.
But let's do ICT first.
Okay, so ICT. So currently it's referred to as invasive cervical traction. You're right. We have to think about that I. But, maybe Eileen's cervical traction. So it is, we recommend home traction trial as a precursor. I don't find it all that reliable, and I've told Bolognese this over and over again. I still recommend it at times, but you find it reliable?
I find it helpful. The problem I have with it is when it's causing pain or when there's no clear change. For me, that doesn't rule it out, but it makes it harder to get Paulo to accept the patient.
Yes.
And that's a big problem.
Yes.
And I mean, he's pretty open to discussion with me, but I can't really twist his arm. Whereas if I have a patient who has clear-cut response, it's a slam dunk. It's just no problem at all.
Right. I agree. Oftentimes people will say that it hurts, but I think it hurts because I think it's just positioned incorrectly, or they're positioned incorrectly, and not by any fault of theirs. I just think it's just hard to ask a patient who's so chronically ill to sort of do this home traction.
Well, yeah, and you can't do it in any patient whose POTS is not well controlled, because just by definition, you're putting them in a chair, they're going to faint.
That's right. So it confounds the results. I feel so. I just don't find it all that reliable. So the way I do it is, clinical history, obviously, my exam, which I sort of feel, and I do certain provocative maneuvers without them even realizing it. In fact, I have them flex their neck and turn right and left, and I have my thumbs on their C6, C7, and I sort of feel how it moves, and I've actually sort of picked up on
I need to watch you do that. I don't know how to do that.
I'll show you.
I do, axial and extension and traction.
In the office.
And I feel around a little, but I don't really know what I'm doing.
I could show you.
Yeah, I'd like to see that.
And then also the way they sit, sometimes you can sometimes tell a lot, or even their description of symptoms, like the bobblehead.
Right,
idea,
bobblehead and history. I mean, clearly the patient that says every time I'm upright, every time I ride in a car, every time I take a flight, every time I'm on a train, everything gets worse. They have CCI until proven otherwise.
Exactly. And then, of course, the imaging, right? So then we take the imaging, we do the measurements.
But often that doesn't tell us.
Right, I agree. But sometimes, it looks a little funky. That's what I say. And sometimes the clivo-axial angle will be in the borderline range, between 135 and 145. Usually the other measurements are fairly normal on just a supine imaging. And then when we do the ICT, we actually find where they're abnormal. But regardless, before we get there, so that's actually how I start to sort of stratify what patients I'm considering the ICT. And that, like I said, I still will give them the instructions of the home traction trial. And if they say it was like remarkably helpful, then obviously it's slam dunk. But even when they say it wasn't that great or it worsened symptoms, like sometimes I'm not sure, I don't necessarily find it all that reliable.
It is also helpful if they have rebound.
Right.
So they do it and it didn't help or it hurt. And then when they release it, if they say, I really was worse for like 3 hours or a day, that's really significant.
And I always tell them that that's actually a positive traction trial.
Exactly.
So
that's what I say.
As opposed to if it's a delayed onset of flaring of symptoms, then it could be PEM, right? So, and I try to make that distinction with them. And so then let's just agree that now we want a patient to go for ICT. So that's a very long pipeline, as I say. In fact, and you should start doing this if you aren't already doing this, I've already been giving them the new patient questionnaire to get started on it even before Jeff gives it to them, just because that seems to be the bottleneck for a lot of our patients because they are so chronically fatigued that it takes them a lot.
50 pages long.
It's 50 It's so ridiculous.
Paulo's questionnaire is like my leaky gut protocols. Over the last 9-10 years, it has literally gone from 2 pages to 50 pages, color-coded numbers. It's overwhelming. Right. I sit there just to scroll takes 10 minutes.
Right. So I've been actually giving it to them at their visit. I upload it to their chart and I just say fill it out when you can. That's a great idea.
I haven't thought about that.
Yeah. And so have you gotten the most recent new patient questionnaire? Because there's a new one as of literally 3 weeks ago.
Yeah, I think I have it somewhere.
Okay, good. So you should do that because then they already have it ready.
Yeah, no, it's a good idea.
Yeah. And so then when Jeff contacts them, here's your questionnaire, here's the back. Right. And then they just have to upload their imaging. So then it goes to Jeff Wood, who's the triage coordinator, and then he packages the questionnaire and the imaging, and he sends it all to Dr. Bolognese, and who does a second opinion letter.
Right, but that's where the other bottleneck is.
It is. Well,
his office is.
I know. That's the other bottleneck, which is why I try to help with the first bottleneck. But I can't do anything about the second bottleneck. I mean, people think that we have magical powers, like I could just
it's
knock
really,
on his door.
really bad.
Right. But I will say he recently said that he caught up. So right now the wait time is a lot shorter than it has been. So hopefully that's not a problem anymore. But regardless, then he writes his second opinion letter, which he just sort of summarizes everything and then reviews the imaging and then summarizes the measurements and then decides what the assessment is and what the plan is. And it's usually in agreement that ICT is indicated. There's a couple of things that they need to do in the meantime with regards to the neurocognitive assessment or the neuropsych assessment and some other potential workup things, diagnostic markers. But regardless, then you can schedule the ICT. And then you go for the ICT. So what is the ICT? So the ICT is you go into the hospital, into the OR, and you're put in a halo, and it's attached to a traction device, and you're awake.
Let's be clear. Why the reason it's called invasive is that the halo is attached to your skull with two.
Right, but it's not drilled into your skull. It's bolted.
I know,
against
but that's
the
what's
skull.
called. Well, why it's called invasive.
Right. So, but that's barely invasive. I mean, you want to know what's invasive? You should see the craniotomy I had.
God.
This is just that it's drilled up against the skull to keep it tight.
Yeah, no, I know.
And you're given a little propofol, by the way, when that's happened. So
Yeah.
you're out for that part of it. But propofol is very short acting. So the minute we turn it off, you're awake.
My point is that patients don't understand it is not surgery. It's happening in an OR.
Right, it's not
but
surgery.
It's not surgery.
And that's an important point.
Yes.
And actually doing the ICT does not in any way obligate you to the fusion surgery.
Data
which
collection.
Everyone is, and rightfully so, and we should have a whole episode on the fusion surgery, even though neither one of us are surgeons. But for those who fear getting the fusion surgery because they've heard lots of bad things or just have fear of surgery itself, fair, and we are sympathetic to that, and we will have that conversation. But having the ICT, and this is why I wanted to talk about it again, because I don't think people recognize how enlightening the ICT can be for a patient's diagnosis. Because that we learned so much from this process about the patient and what could potentially be contributing to its symptoms. And that is the point of the ICT. And I will even recommend ICT to patients that I don't even think should have the surgery for various reasons, right? Not everyone is a surgical candidate, not only because they don't have the diagnosis that would indicate the surgery. So there are other reasons why surgery would not be a great idea for a particular patient, but I still think the ICT is important for various reasons. And so you're given a little propofol, the halo is put on.
Can I interrupt you again?
Mm-hmm, of course.
Just to emphasize something you said sort of quickly. The ICT, I think even for patients who say, I'll never do the surgery no matter what, the ICT is a critical piece of data collection.
Absolutely.
Not to convince the patient to have surgery, underline, not to convince that patient to have surgery, but to give me or you or the patient's physician the information that we have significant instability, let's say it's positive, that we have significant instability here, and what other non-surgical interventions can we do and explore, including more radical, in quotes, more radical ones that you might not consider if there was not full-blown instability. So
absolutely.
It's so important not to rule out this piece of data collection out of saying I'll never ever do the surgery. That's not a good reason.
Okay. And I will say, and I know that you'll agree with me, Dr. Bolognese looks for reasons not to.
He doesn't want to operate. That's right.
He goes into this going, I don't want to operate on you, and he will look for reasons why he won't operate on you.
I agree.
He is not scalpel happy. That's a hard phrase to say. Scalpel.
He's not a carpenter with a nail.
That's right. That's right. Exactly. So then once you're awake and you're on the traction device, we just, we start with low weight and we raise the skull up off the cervical spine and we let it just sort of settle for a little while. And then after a period of time has lapsed, we ask how those symptoms are. I should say before we start, we ask what your 5 most prominent symptoms are. We usually already know from the questionnaire, but occasionally patients will arrive for the ICT and something has been, worse in the last few weeks. So we might change the priority of the symptoms that we're assessing for. And so we'll ask how those symptoms are. And if you say better or worse, we ask percentage-wise. And that usually patients need to know that we're asking percentages because they're often surprised that we're asking about a percentage because they just feel like it's either better, it's binary, it's better or worse, right? But he likes it at least 80% better. Again, he looks for reasons not to perform the surgery.
And granted, it's very subjective.
It's very subjective.
And I understand why patients kind of roll their eyes. What do you mean you're going to do this on percentages? But there's other pieces that you're about to describe that are not subjective at all. They're profoundly objective. But in fact, that subjective assessment is enormously helpful. I'll say it as the referring physician. When I look at his report and I see that the patient says at rest they have 80% brain fog, and at 35 pounds, now they say, wow, it's 15%. It's like, holy mackerel, there are nothing I can do in this world would accomplish that.
That's right. That's exactly right. And that's often what we see. The more weight, the better the symptoms improve, or the more the symptoms improve. And so, it's very methodical. It's very objective in the sense of like how much weight we're using, how much we're increasing the space of the joint, and we actually take X-rays at every increment, and we do the measurements at every increment. And in fact, if you look at his report, you'll see the measurements on traction, off traction,
right.
And we find, or I always say we, but it's actually him doing it.
Right.
He finds the sweet spot, as I refer to it, which is the spot where there's the most clinical benefit, so 80% or above of at least 3 of the 5 symptoms, and there's a correlation of a morphometric change where it would make sense, because that is actually what addresses the subjectivity of the report of clinical benefits.
Exactly.
Is there a correlative change of the morphometrics that would at least start to explain the clinical benefit being reported by the patient?
And in fact, and this is a source of frustration for the referring doctor, i.e. me, if he doesn't see those objective changes, patient goes from 80% to 20% on all 5 things, meaning a 60% improvement. If he doesn't see the changes, he won't operate on that patient.
That's right.
And it's incredibly frustrating for me and the patient. But in fairness to him, what he's saying is, I don't know what to do in the surgery.
Exactly.
I mean, what do I do? There's nothing for me to fix.
That's
yes,
exactly
you're better
right.
with traction, but I don't know what to fix.
Right, because he doesn't know how to fuse it. Because what he does is when he goes in intraoperatively and when he sees it grossly, he's got the measurements of which he tries to simulate. And if he doesn't have those measurements, he doesn't really know how to fuse, as opposed to, just eyeballing it, which he doesn't prefer to do. And that's why the ICT is so critical.
And that is what other surgeons do.
Right.
I mean, the few other neurosurgeons in the country that will even do this work, they don't do ICT.
They don't. This is he's the only one that does it.
And it's granted I'm biased because I really like him and I bought into this concept completely.
Well, because we've seen patients
so that said,
go from bedbound to hiking.
So, but that said, as a full disclosure, then thinking about these other surgeons who are very, very good neurosurgeons, and some of them are, world famous people. It's I don't want to say a hunch. It's based on looking at the films, the images, and talking to the patient and saying, yeah, I think you need a fusion. Well, that's a little scary to me.
Yeah.
When there might be a way, or there is a way, to objectively define how much of a fusion you need, and there's an image I use with patients to try to explain both why I think something's wrong and what this is. So it's a really crude image. You'll laugh at me again. So it's the bottle and the cork, okay? The brainstem is the cork. The bottle is the foramen magnum, all right? So that brainstem is going down, right, when they stand, and that's why they get so sick. And the surgery is to pull it out and leave it up, okay? And the whole thing with the ICT is they go into Paulo's OR, they're like this, and when he does his traction, he can define it objectively and subjectively.
Right.
The challenge is when he does the traction, if it doesn't get pulled out, he doesn't know what to do, even if they feel better.
Exactly. No, I think that's a really nice way of explaining it, David.
Okay.
I'm glad you shared that with me because that's a really great visual for patients to sort of understand what it is why we advocate for the ICT so often.
Right.
So so that's exactly right. That's exactly the whole point. And so while you might feel an improvement, if there's no change in the anatomy, he doesn't know what to do to fix it. As a surgeon, again, right? I mean, there still might be ways that we can fix it.
It's also why he will tell those patients, all right, let's repeat it in 3 to 6 months. And I've had many patients come back, and now their BDI changes, and he knows what to do.
Right, exactly. And patients get so frustrated because they have to then fly back again, and we get it. I really do sympathize with that. I know it's, in fact, we would like other neurosurgeons to get involved. I would love someone, on the west side of the country who would be willing to do the ICT.
Yeah, actually, that's what I don't get. I mean,
I don't either.
You don't need to be the neurosurgeon
to do
Bolognese's type neurosurgeon. You're not going to do the surgery, but why can't we get some of these centers to do ICT?
I don't know, actually. In fact, Bolognese has had visiting neurosurgeons from the UK and also from Australia who now have gone back to their countries and are setting up ICT practices. So I don't know why someone from California can't come out to New York.
It's just nuts.
Yeah, it is nuts. I agree, because it would be nice
that would change this radically.
It would be, yeah.
Anyhow, I interrupted you again.
Anyway, well, I mean, so and then during the ICT, this is the other really great thing about what we do there in the OR. So first of all, it does take a couple of hours because we let things settle. It's not just like we lift you and go, how are you? You know, it's like.
This is not a deadlift in the gym.
No, in fact, it's, we stand around and we stare at you for a little. I mean, I've been in there with Bolognese for ICTs when I'm in New York, but, it's really as true, actually. We all stand around, like this, like looking at the patient before we even talk to them, because we want things to settle a little bit, right? It's not necessarily an immediate response. Right. In fact, it often is not, because there's now blood flow. Blood can get places where it hasn't been before. So we allow for all of this to calibrate to some extent.
It's a really important point. Yeah. Let's emphasize that point.
All right.
Cork in the bottle,
Me yelling is not emphasizing
the implication of the cork in the bottle is the
like
pressure on the brainstem neurons and nerves, but it's also the blood vessels are crushed. So if you've watched the small vessel episode we did earlier, and now you're watching this, think of those small vessels stuck inside that bottle. Okay?
That's right. And in fact, collaterals that we had brought up in that episode actually do form if you've been chronically compressed, right? So now you have also these collaterals, but all of this compression and you relieve it. Now blood can get places where it hasn't been before. And sometimes it takes a little bit of added time for the blood to get there to sort of deliver its goods, if you will.
And take away the bads.
Although I don't think that happens
I know.
enough. There's not enough time for that to necessarily happen, but at least for blood to perfuse, we allow some time. So, we just stand. He always crosses his arms, which is why I'm doing that. He stares at patients. But and then we'll ask about your symptoms, and then we start and we document it, and you've seen the graph and the chart, and then we lift it more. We put more weight on and lift it again. And we just repeat that over and over again. And we take x-rays at every increment. So that's what's
it's not only x-rays, he's also videotaping it. And I will tell you, he's sent me the videotapes on some of my patients, and no exaggeration, it literally brings tears to my eyes.
No, I agree.
I'll have a patient who's been bedbound for 2 years, wearing ear protectors and eye masks, can barely speak, literally can barely speak. And then he sends me a video of the patient, and they're talking, and their eyes are open, and it's like you just want to cry. It's unbelievable to see.
The first time I saw that, I did cry.
Yeah,
because it was
no,
a
I'm
patient
saying
who
I
was
do.
just like you described, literally in a room, dark room, glasses, earplugs, speak at a whisper, if at all. And it was completely different under traction.
It's incredible.
And patients who are really photosensitive, can't bear this, the sunlight or even lights in their house. As you know, the OR with their fluorescent lights, it's really hard for them.
Actually,
and then under traction, all of a sudden that doesn't bother them. So anyway, so then let's say the ICT. So that portion of the ICT, we found the sweet spot. But also during the ICT, we also do transcranial Dopplers. And I've brought this up before in previous podcasts, but it's an important data point. We prove 9 times out of 10 that there is low cerebral blood flow velocity.
Let's make sure they understand what that is.
So a Doppler study, it measures the velocity of flow. And we regularly use them on stroke floors in hospitals.
It's a non-invasive procedure.
It's non-invasive. It's an ultrasound
with a probe sitting here measuring flow.
Exactly. We do it on the carotids. We use Dopplers even to look for DVTs. So we actually do it on particular cerebral vessels, and we can actually assess the cerebral blood flow, the velocity of it at least, and it's almost always low. So it shows there's low cerebral blood flow, which contributes to the small vessel disease that we talked about in the last episode. And then the other thing that we do is often, not always, it really does a little bit depend upon the particular clinical history of the patient, but we do ICP bolt monitoring, which is just a crucial data point for a lot of our patients who almost always have some level of intracranial pressure abnormality, right? Because most often these are obviously connective tissue patients of an EDS type, so more systemic, so are at risk of things like CSF leak, fistulas, so can have spontaneous intracranial hypotension, but also very often will have elevated intracranial pressure, sometimes a mixed picture, right? In the skull is high, in the spinal canal it's low, vice versa. Sometimes the cranial cervical instability is the cause of that. There's blockage of good CSF flow, so sometimes you can have altering dynamics of the cerebral spinal fluid flow, changing the pressures. And it very much, and also there's a level of dysautonomia that's involved, right, in terms of the ability for the cerebral spinal fluid to flow appropriately. And that can create pressure changes, which can definitely contribute to a lot of the symptoms that we hear about. And it's always something on my mind now when I'm talking to patients. It's not just like, oh, you need, midodrine or Florinaf, or I think that sometimes we need to assess you for intracranial pressure problems.
So I don't, other than risk, which I don't mean to minimize, but I don't know why he doesn't routinely do it on every patient, and he doesn't.
He doesn't.
It's frustrating.
Right.
Number one, and number two, we should add that doing the bolt, the ICP, measuring the pressure.
He does it supine, sitting.
Yes, he does it in multiple positions, even when they're walking. Okay.
Yeah.
Picture that compared to the gold standard way of measuring for intracranial hypertension, which is you lie down on a stretcher, you're in a left lateral decubitus lying on your side, and hopefully some doctor does a spinal tap and remembers to measure the opening pressure. And so now you have a pressure that, say it's 21, and that's not regarded as abnormal by most people.
But it's abnormal for our patients.
But it is abnormal. And it's also, you're 21 lying flat on your side, not moving. Is that representative of your life? Is that a representative of the dynamic changes in your intracranial pressure? And no, the answer is it is not. And that's the ICP is so valuable for that.
It really is valuable, and he will actually, if there's clear evidence that you have intracranial hypotension. I mean, he will occasionally do blind patches, which, it's hard to get anybody to do a blind patch without concrete evidence of a CSF leak.
Right.
But he'll do blind patches to see if that just helps, because sometimes you can't always identify a CSF leak. And, I've gone to a lot of these CSF leak conferences, and I'm part of this neurointerventionalist group. And the one takeaway that I have as just a neurologist and not someone who fixes these things is that all of these specialists have their own like pet ways of identifying leaks. And so these CSF leak clinics that exist, like at Duke and one at Cedars-Sinai, it's a collaboration amongst like the neurosurgeons, the neurointerventionists, the neuroradiologists, and they know exactly what kind of imaging to order and how to order it and what to look for and how to look for it, how to fix it, what would be best for this particular patient. I mean, there's a lot of like fistula kind of evaluation to be done, and so those leak clinics are really valuable to these patients because it's so focused in on that one question, right? And so I advocate for those leaks, and a lot of patients will ask me like, is it worth me going to my time to Duke? And I would go, absolutely, because that's what they do all day, every day. Right. So they've developed like their own means of like how best to look for that leak, because a leak can come from other things other than just a tear in the dura, right? So there's other things that can cause, I shouldn't say a leak, there's other things that can cause intracranial hypotension other than a dural leak.
Well, it doesn't even have to be a leak. It can be the fistula you described.
Right, exactly. And I've learned that there's actually other more obscure and less common things, but other things actually, even where an osteophyte sits, can be pushing into a certain part of it.
This is a question for you.
Yeah.
So our patients are appropriately and afraid to have spinal taps done, and most of us don't want to do spinal taps because we worry about a leak in our EDS patients because the dura is connective tissue.
Right.
Does the bolt ever cause a leak?
No.
Why?
Because it doesn't really. It's a pressure transducer, so it doesn't really penetrate.
So it's not penetrating the dura. Okay. So that's a really important point that we need to make sure our patients know pre-New York.
Right.
Because that's one of the things that I think they often fear but don't ask about.
Yeah. But patients, I always tell patients, I talk about the entire procedure that they should expect. Because when I order an ICT, I don't know if it's right, order it, as if I'm ordering bonies
Refer
around.
for it.
If I refer for ICT, I also say ICP bolt monitoring. So I'm always explaining to patients what I'm asking for. But yeah, so it doesn't cause a leak. So lumbar. So just my lumbar punctures, I have never had a leak.
Well, theoretically, you probably don't have connective tissue disease.
No. I meant the ones that I
performed. Oh, you do. I'm sorry. Sorry.
That was so weird. I think my theory, and I think I've said this before, my theory is because, when neurologists do it in clinic, we have anatomical landmarks, but we can't see the foramen, right? We can't see where we're going. So we go very slowly and very gentle because we're doing it blindly, basically. Just with fluoroscopy, you can just see it. So I think they just are a little bit more aggressive because they can see the hole, right? They're just going to go in and get the fluid. But I obviously go very slow because I don't know where I'm going because I can't see, but I'm using my landmarks. And so I've never caused a leak in a patient.
Good work. All right. So the ICP is done. The ICT is done.
So and then he does like an entire report from the ICT, and he deems you whether you've passed in flying colors or you failed. No, obviously nobody fails anything. But you're either a surgical candidate or you're not. And then he doesn't like to do, of course, if you are a surgical candidate and decide that you do want the fusion, because sometimes actually patients can't believe how great they feel under that kind of traction, right? Yeah. So they're like, this is amazing. I never thought I can feel this normal ever again. Right. Because once they're under traction, like everything just improves, and they decide that they want the fusion. He doesn't do it in the same visit, of course, because he prefers patients to go, unless, I should say there are obviously exceptions, but he in general prefers patients to sort of go back home and think about it, talk to their family members about it, and make sure that they understand exactly what the fusion is, what the risks are, and come back being an informed patient.
Yeah, I find that protocol really frustrating.
You do? I think that there's some validity.
There's some value. There's some value, but for the patients, these are very sick patients, and they're.
Well, I was going to say,
I have patients who rent a van so they can sleep in the van. They drive 3,000 miles, and then they have to come back, and then they're going to go back again. Yeah. I think there should be.
He doesn't want them to rush into the surgery.
I know all the reasons, and he's right, but we have an exceptional situation, and there should be the ability to make exceptions. And he does occasionally, like I have patients that come from Europe, he'll make an exception. But I think that needs to be a wider window for those people.
Yeah.
The other problem, here we go again, the other problem for the delay, which is actually, I don't want to say the real reason, but a very big reason, is the goddamn insurance companies.
Right.
He then has to get approval for the surgery.
surgery.
And they, of course, will not approve it. They don't know what you're talking about. And on top of that, the latest scam in the insurance business is you can't go out of state for surgery. You can't go out of state for a specialist. Even though you're paying $50,000 a year for PPO coverage that says you have out-of-network coverage. Oh, no, we didn't really mean it like that. So it's a huge problem.
It's a huge
and
problem.
That's another reason for the delay.
Right. So that's another reason why, because his office works on getting insurance approval, of which they often have a hard time. And how many letters have you written? I know I've written a million, that explaining that he's the only one in the country that does this, and that's why this patient had to fly there.
Right. And sadly, that's why the European patients can go for their ICT and their surgery, because they're paying cash.
Right. Exactly. But he still prefers some time with the ICT and the surgery.
And that's
but
reasonable.
I will say he has made exceptions for those that have been completely bed bound for a really long period of time. He will do the ICT and then the surgery following the following week or something. And I've actually had, a good 10 patients where that had happened too.
But not just
but you're right.
in
But I realize that most of them were able to pay cash in the meantime, while some of them were Americans.
But I think we want people to understand it's not a medical reason that he couldn't do the surgery next. It's not that they have to, quote, recover from ICT.
No, right. That's a very good point. There's technically no recovery period expected. I will say that there are patients that have rebound following ICT.
Yes, they can have terrible rebound, and of course they have PEM and getting to New York and going through the OR and all that.
Yes, and so sometimes I have to manage the rebound from the ICT, which is manageable. And I always tell patients, like, this is not insurmountable. We can get you back to the baseline you were prior to the ICT, and we do. And I've yet to have a patient, and I don't know if you've had, where the rebound from the ICT was so bad that they never returned to baseline.
No, I haven't.
Me neither. So, but yes, so then there's some recovery from the rebound. If rebound occurs, it doesn't always happen. Sometimes it doesn't, so yes. And he likes to just make sure that a patient is showing up for surgery very well informed and very willing to undergo the risks, and then of a complete understanding of what the recovery period is like from the fusion.
And actually, again, in fairness to Paulo, after ICT, if he recommends surgery, he's usually recommending at least 4 or 5 other things in terms of blood work, additional consults, additional imaging, before he's ready to operate.
I mean, in some respects, it's a more standard, like pre-op kind of clearance that still needs to happen. But sometimes he does want additional imaging, especially in light of what we know now with regards to, for example, compression of the internal jugular vein. Or even a tethered cord. It's not. He likes to sort of know what the deal is going in for a fusion, right? Are there other things that should be addressed first, maybe?
Yeah, I mean, it's fascinating to me when I think about my history here with this illness, or this, I don't want to say disease, this neuroanatomical problem. So I never heard of such a thing until 10 years ago. And in the last 10 years, working with you and working with Bolognese, the changes in this mere 10 years, which is nothing in medicine, is enormous. I mean, back in the beginning, that questionnaire was maybe 8 pages long, literally. And, he didn't do CTA, top to bottom, looking for eagles and everything else as part of the routine pre-op. And now it's all these other stuff, which is a reflection of how much in these short 10 years we all have learned as we've worked together on these patients.
Right.
Which is fantastic. I mean, it's
it's
very
great.
Complicated and it's hard to keep up with sometimes, but it's fantastic.
It is fantastic because I think it helps patients more and more.
Yeah.
And, when we find, I always say, if it's like cockroaches.
Oh, here's a good one. Yeah.
If you see one cockroach, like there are thousands behind the wall. If you see one,
you must be from New York.
If you see one compression, there are likely others, right? Because it does. Although I will say the internal jugular vein seems to be the exception, because it could be due to a bony prominence just sitting on the jugular vein. Right. But in terms, and I know we plan an episode on compression syndromes, but in terms of some of the more common compression syndromes we see in EDS patients of the abdominal and pelvic cavities, usually if there's one, there's another, and by that also includes TOS. Right. So. And it's an indicator of basically how compressible your vessels are. right? So if your vessels are very compressible because the outer layer is connective tissue, and so sometimes the slightest, mechanical touch can just cause it to collapse. So if you have that risk factor, you get compression syndromes, because if a ligament just sits in the wrong spot, it'll just easily compress a vein or an artery. And so, so I always say, if you have one compression syndrome, look for others. And so I have several patients where
it's like
we're
STDs,
searching for
same kind of
compression
thing.
syndromes, right? Right. And it's proven to be true, by the way. So where there's been one, I have found at least a second, if not a third.
Yeah, well, that's what
So,
I'm saying. That's why I think it's worth remarking on, and how important it is that this workup for CCI in 2014 has turned into a workup for everything from here to here. And
Right.
now, after what's been going on that we've been talking about with other vascular compressions, basically from here to here.
Yeah, everywhere.
yeah.
And again, that's what I preach to anyone who will listen, right? Connective tissue is everywhere. Like, we can't just think it's just about the joints, because it isn't.
Right.
Yeah, so I'm going to get off I'm going to end up somewhere else from where I started. But yeah, so he does like to sort of know, everything, or at least as much as he could potentially fix going into any surgery, right? Because technically, if you have both tethered cord and CCI, which very commonly coexist, you could choose to do the SFT first, right? You could decide that, and he's not against doing it first. But sometimes it uncovers, more of the symptoms from the CCI, and vice versa, though, right? So,
well, and he's occasionally doing both at the same time.
Right.
Not often.
Not often. Not both of those, but he will often do, if there's a compression of the IJV, especially from the styloid or the C1 tubercle, he will just remove those bones while he does the fusion kinds of things. So he'll combine things if he can, if he thinks that it's,
Yeah, I had one patient who did
both the
pretty
tethered
young
cord
person, like 20 years old.
Okay.
And he did a fusion, jugular, the
all in the
C1
same,
shave
not in the same
and
surgery.
the tethered cord.
In the same surgery, or in different days?
Same day.
Wow.
It was like 12 hours.
Wow. Okay.
But she's at college now.
That's fantastic.
It was great.
That's fantastic.
Yeah.
Oh, wow. I'm really excited to hear that story. You should tell me about that patient.
I will.
Okay. So I guess what I always try to advocate to patients is that the ICT is really about, we want to answer the questions of, if we put some space between your skull and your cervical spine, do symptoms improve? So that's one question. Do you have cranial cervical instability? And if so, is the cranial cervical instability contributing to your symptoms? Cranial cervical instability, there's a horizontal component, there's a vertical component, there's a rotational component. So if there's a strong horizontal component, it may not even respond to the ICT, which is some of the reasons why you can have improvement of the symptoms, but no change.
Those
no
are the
correlative,
patients that I've had.
Right, exactly. No correlative change of the morphometrics. So it's these are complex questions that can really only be answered with the ICT.
Right.
And then we get the transcranial Doppler results. We get the ICP bolt monitoring results. We get a lot of information about this patient from this one procedure, which I'm not pretending like it's easy or simple.
It is
in
pretty
any
easy
way.
and simple, though.
Well,
if
you think about getting there, first of all, the whole process to even get scheduled.
But I mean, as a procedure.
As a
I
procedure
think it's
itself,
important to say that.
You're absolutely right. The procedure itself is actually very simple.
Right.
You're awake, we're awake. We're interactive. We make jokes. They play music in there.
Right.
So we try to make it as pleasant as possible.
Get to hear Paolo make his jokes with that great Italian accent.
And his very bad jokes,
Yes,
which are usually conservative and Republican.
A little bit upsetting. Can't believe it. He may be the only Republican I'm willing to
I'm
work
always
with.
like warning him, you're being a little too politically incorrect. But he's a really good guy.
Oh, he's great.
And he's a great surgeon.
Yeah.
But so you're right. The procedure itself is fairly simple and straightforward as far as procedures in an OR go. But the whole hassle about just even getting to that point is, I guess, what I was referring to. But it's just such an important diagnostic. So we use it as a screening tool, but also as a diagnostic tool, right? So I think, and if you are not deemed a surgical candidate, we are armed with so much more information about this patient that we could not have gotten otherwise.
Yeah, I mean, it's a critical diagnostic tool.
Right, exactly.
For me, it's the nuclear equivalent of the Nasoline test. You know what I mean? It just tells me so much information
Right.
and tells the patient and the surgeon.
Right.
And okay, so you just choose not to have surgery if he's even though he's recommending it, fine. But now we know what's going on. We know how to begin to suggest other ways to try to stabilize you. It won't cure it the way surgery might cure it.
Right.
But there are still other interventions.
There are other interventions.
You know, we can maybe do a whole episode on those other interventions.
Non-surgical interventions, yeah.
But it's just so important. It'd be like saying, I'm not going to measure my blood pressure because I don't want to take blood pressure medicine. I mean, that's just stupid. Sorry, it's ridiculous. So,
I'm like that sometimes. I'd rather be ignorant.
Well, yeah, I'm not going to check my ApoE, so that's true.
I know. My PCP told me I need some screening stuff, and I'm like, nah, I'm good.
So I wanted to bring up pre and post still, and also I want to come back to the TCD, to the transcranial Doppler. In fact, that's a new addition to his procedure. He didn't always do it.
No, he didn't.
That's another example of the knowledge evolution involved in this, which is so exciting to me.
Mm-hmm.
And in fact, but you tell me if this is correct, I'm pretty sure it is, when he does it at baseline, we're seeing that the reported 30 to 40% decrease in blood flow to the brain.
Yes.
Just think about what that means.
And under traction, it goes up.
And thank you, you stole my line.
Oh, sorry.
Under traction, it improves.
Yeah.
How much more dramatic can you get?
Right. I mean, these are these
Imagine
are
if you had a live SPECT scan pre and post during ICT.
No, it really is amazing. No, in fact, what we're working on right now is actually doing things like venograms on traction.
Right.
So that's exciting. In fact, I mean, it's going to happen probably in the next year or so. We're working on that. We have a new, he's not new anymore, but we have a neurointerventionalist that's part of our team.
Right.
And he's actually speaking with other hospitals as to how to get venograms done while patients are under traction. Yeah. So it's going to be like this really important piece of a diagnostic procedure tool. That's a lot of words. I don't think that makes sense, but you know what I mean.
Sense.
that arms us with data that we could potentially help our patients even more than we try to do now. Right. And so that is what is so exciting about being so on the forefront of this field in some respects. Other than the frustrating part of there's so much uncertainty and so many lack of answers to important questions that could really help our patients. We're getting there.
Yeah.
You know?
So the other takeaway in terms of the transcranial Doppler. This is obvious. You and I have talked about it. But the other takeaway is that should be part of our basic workup in the office.
I think we should buy a transcranial Doppler.
It is.
Do you have $60,000?
No, not this week. But, imagine being able to do, don't laugh, a Nasoline test and a transcranial Doppler.
Oh, that would be.
Just
no,
think about
why would I laugh? That would be
fantastic.
because
I overdo the Nasoline test. But my point being, it shouldn't be looked at as this uber sophisticated only use in the OR tool. It should be in our patients, and maybe in lots of other kinds of patients, a routine part of the diagnostic evaluation of patients.
100% agree.
And then follow it in the same way I use the Nasoline test, follow it when we try to juggle meds and titrate meds and see. If they started at 40% and we put them on aspirin and lumbrokinase and pentoxifylline, and suddenly it's down to 20%. Agree. Oh my God, what an accomplishment.
No, then we can prove the efficacy of our pharmacologic management, right? As
so if anyone has $60,000,
we could use $60,000 for a transcranial Doppler in our clinic.
God, would that be great?
It would be great. Believe me, I've thought about it. If it wasn't so expensive, I would have bought one of my own.
Yeah, that would be great.
It would be great. But we've run out of time.
No, we still have to do pre and post, but we can do it very quickly.
I don't think we could do it that quickly.
Yeah.
I was going to say that we can add it to when we talk about the fusion itself.
No, I want to do it now.
Oh. Okay.
No, it can be quick because it's not a major surgical procedure.
I guess my bladder is of no interest to you.
Oh, sorry.
It's okay.
Should have gone in between. That's what I did. You're our producer laughing. All right, really quick.
So pre and post. What do you recommend pre?
Pre, I recommend bring all your medicines. I'm serious. Bring your medicines. Be prepared for post-exertional malaise after and during the trip. Probably reasonable to take extra mast cell meds if you're an MCAS patient because the procedure may provoke mast cell activation. It's causing some discomfort and some anxiety,
Yeah.
which is a provoker. Fluids, and basically the same information after.
Yeah, a lot of patients will ask me, should I flare my symptoms? Because some people know their triggers.
Yeah.
And should they be having a bad day when they go for ICT? And I don't think it's necessary.
I don't think so either.
We agree.
I don't think so.
Yeah. Because if this is an anatomical problem and you may be feeling okay on that particular day, but if we see abnormal morphometrics turn normal and you feel a difference, like then that's a positive ICT.
Yeah, I don't think they need to do that, because the fact is their baseline is not so good, so flaring doesn't make any.
Right.
You know, I don't.
Exactly.
It's
So
not.
you
It's
don't-
not like
right.
it's not like we do traction seated because we need gravity's effect versus
Right.
supine. It's not this. It's not
Well
like
said.
that.
Exactly.
Okay?
That's exactly right.
Yeah.
Yeah. So no real, you don't have to flare your symptoms prior to the ICT, but I agree with everything you said.
Right.
That's what I say. Take all your meds, use what you need, be less anxious, make sure you're well hydrated. You've got a good intravascular volume space.
And be
Right.
psychologically, emotionally
Psychologically
ready
prepared.
for a couple of days of increased fatigue and possible
Right.
PEM afterwards. That's kind of the same thing you might feel if you had to go to the dentist.
Exactly. Oh, exactly.
Okay.
That's so
And
true.
you can plan to go home in 2-3 days, or the same day.
Or the same day. Many patients do.
So yeah, I did it in 90 seconds.
Right, and we already talked about the rebound potential. So might be some rebound, but completely
Right.
manageable. And just call your doctor. It's probably one of us to manage those rebound symptoms if you have them. But many patients just feel fine. They rest. We allow them to rest for a few hours afterwards,
Right.
and they are just well enough to go home. Occasionally, we keep them overnight if we want to do more extensive bolt monitoring.
Right.
But for the most part, you feel at least at your baseline by the time you're discharged.
Okay.
All right, we did it.
Did it. All right.
Thanks for joining us.
Thank you very much.